Are you able to listen, Professor?
Yes, thank you. I can listen you.
Yeah, please start the lecture.
Okay.
Yeah.
I will try to connect my screen.
Yeah. Share screen, please.
Okay.
All of us do major rectal surgeries and do anastomosis, and we always do a diverting ileostomy, temporary, but again closing the ileostomy, another admission, so it needs not only money but also another procedure. I think Professor has devised one beautiful thing to avoid ileostomy. So he will be presenting.
Okay. One second. So we know the rationale for creating a diverting ileostomy is to avoid the septic complication of anastomotic leakage. Moreover, the anastomotic leakage is directly linked to the local recurrence and the reduction in the overall survival rates in patients with rectal cancer. I won't talk today about the diverting stoma indication or the risk factor for anastomotic leakage, but I will talk just about this, let's call this alternative to diverting stoma. We are conscious that derivative stomas will not reduce the risk of leak, but we are also aware that it will prevent from septic complication and reduce the risk of reoperation. On the other hand, the diverting stoma increase the rate of complication, like small bowel occlusion, electrolyte imbalance, acute renal failure, and last but not least, we had the second operation for stomach closure with its own complications such as wound and abdominal abscess, the anastomotic strictures, and occlusion and leak. Not to talk about the quality of life of this patient and the aesthetic result of stoma and stomach care. So we were looking for an alternative to stoma that, giving the same protection, could eliminate the adverse effect of stoma. I don't know if you can see my presentation.
Not yet. I think you need to go. Now you can see the share screen option coming in the down green one.
Yes. Yes, so, the green one.
You can share the screen.
Yes.
No, you are not sharing. You have to share the screen. First open your PPT, then you can share the screen.
Okay. Open. Okay. Can you see that?
No, we are seeing you only. I think some format. Are you on a MacBook?
Yes.
I think then you are on slideshow, or you can present without a slideshow. Have you shared the screen?
Let me check. Okay. By what? Okay. You see now?
Not yet. We are seeing you, but we are not seeing the PPT.
Okay. Okay. Fine. Now?
Yeah, definitely. We are able to
Okay,
see.
perfect.
You can make it full screen if you can. Otherwise,
Okay.
it's okay. Otherwise, it's okay.
So as I said, I won't talk about the indication or risk factor for ileostomy creation, but I will talk about this new device, new alternative. I will talk about this device description. I will show you a small video and device management and our experience as well. So the ALPI tube is a medical silicone tube with a diameter of 20 French, with a balloon occluding the intestinal lumen of 20 cc, with a semi-rigid mandrel for easy insertion of the device, as a cage system to protect the drainage holes that also allow a possible vacuum aspiration of the enteric fluid if we need. As a blue tip and stria which is radiopaque and along the entire length of the tube, as a patented distal end with a not air balloon shape and an anti-kinking and not collapsing with the stabilization flanges, and as a retention flange at the end of on the external side of the device. This is the small video. We start with the making of the secopexy with a 4-row stratific suture. We make a hole where we want the device enter, made a push-string suture to fix the tube once inserted into the lumen of the bowel. The part which is more difficult is to enter the valve, the ileocecal valve, but there are more possibility to overcome this problem. You see the tube enter the lumen of the cecum and immediately enter the valve and the small bowel for 15 centimeter about. So as we think the tube is in place, we then start to inflate the balloon gently, not to injure the bowel wall. So cc by cc, we see the tube, the balloon inflated into the lumen of the bowel. We usually put about 9 to 10 cc into the balloon. We have to look for these capillaries, not to risk to injure the bowel wall. Then we fix the push-string suture at the end, and we then start with the anterior secopexy. Is about it takes some time at the beginning of the learning curve, but as soon as 5 procedure, you will be a master in the procedure. So let's move on. And this is our management for the ALPI tube. We start on postoperative day 1 with clear fluid, and we advance the diet to soft as tolerated by the patient. We wash the ileostomy tube 3 times a day with 100 cc of saline solution, and we do a daily dressing of the hole to check any leak of enteric or purulent material from the insertion site. We can control with the CT enema on postoperative day 8. Once the integrity of the anastomosis is confirmed, the percutaneous ileostomy is removed. Then we will control the closure of the orifice at the first outpatient visit. Our experience, a prospective observational and comparative study. The population is a mid to low rectal cancer patient undergoing neoadjuvant chemotherapy. The primary outcome is an anastomotic leak rate, symptomatic or asymptomatic. Secondary outcome are hospital cost, complication rate, and time to resume any postoperative chemotherapy. We start with a population of the control is a population of patients undergoing anterior low rectal resection plus ileostomy, 52 patients from January 2019 to May 23. The altitude population is a same population with anterior rectal resection plus altitude, 8 patients, but now right now we enroll about 15 patients with neoadjuvant chemotherapy plus radiotherapy plus anterior resection and altitude. The study protocol: post chemoradiotherapy, we do a restaging of the patient with CT, MRI, colonoscopy. The patient has to be negative for distant metastasis. Surgery between 8 to 12 weeks from the last radiotherapy session. Immunonutrition for 7 days before surgery. On postoperative day 1, we start on clear fluid, as I said, and the same management that I said before. I'm trying to be in time. So we move on. This is a clear view of the balloon and the catheter inside with the CT and the enema that will show no complication in the anastomosis, no leakage. From January 2019 to May 23, we operated on 183 patients with rectal cancer. 92 underwent neoadjuvant radiochemotherapy, and as I said, 52 underwent anterior rectal resection plus ileostomy. Of these, 73% about were operated on with minimal invasive surgery. 3.9 had intraoperative complication, but really not in particular, just a spleen bleeding controlled by hemostatic agent. No cases of anastomotic leak in this population. 38.4 went to postoperative chemotherapy, but there is an interesting data that 25% had ileostomy related complication, with about 20% of permanent stoma, and 55% of patients had the postoperative ileostomy reversal complication, and 36 of these patients had lower anterior resection syndrome. The cost in Italy for an anterior resection is 7,200 euros, and the reimbursement is 7,400. The cost of ileostomy reversal is 3,200, but the reimbursement is amazing, is 7,000 euros. From June to December 2023, 21 patients were studied for surgery for rectal cancer. 14 underwent neoadjuvant radiochemotherapy, and of these, 8 had the altitude operation. As I said before, now we have about 15 patients. 100% with minimal invasive surgery, no intraoperative complication noted, no cases of anastomotic leakage. 100% underwent postoperative chemotherapy, and the cost of the operation is 11,000, but the reimbursement, as I said, is 7,400. Of note that there is a shortage of this patient to undergo post-operative chemotherapy or any treatment. There is no difference of anastomotic leak range between the two populations right now, but the good is that there is no second surgery needed for stomal reversal in this patient, no post-operative stomal reversal complication, and there is also a reduction in waiting list time. Of course, till now, RP-tube has a major cost. There is no covering by the National Health Institute in Italy for this device at the moment. But we think that the Lars syndrome will decrease in this patient because we shorten the time to restoration of bowel movement in this patient. But the limits, of course, is the monocentric and the retrospective study and the few sample of patients, of course. The RP-tube for us is a promising and valid alternative to the standard temporary ileostomy in patients who underwent anterior resection for rectal cancer. And we will investigate about better quality of life, but it is very promising because of the no need for stoma management, for quality of life of this patient, no need for secondary surgery, with aesthetic also issue. But there is a necessity of prospective and multicentric and randomized study. Thank you for your attention, and I know it's late evening in India right now. So I hope we will enjoy a good dinner tonight. Thank you for
thank you very much. Wonderful. And I think the device all of us have seen. It is a very good device, and hopefully it will decrease the number of ileostomies. Only tube cecostomy will replace ileostomy in future. I just wanted to ask one or two questions. You said you inflate only 10 ml of the saline.
Yeah.
So if somebody falsely will inflate around 40 ml of the saline, will something happen?
No, it depends on the bowel lumen and the bowel wall. You just go very cautiously, inflate cc by cc until you see the vessel still having blood and pulse on the
correct.
wall surface.
Because if you inflate more, it will cause obstructive effect on the bowel, and that might lead to little bit vascularity. I think you should be cautious. It should be only 10 ml as per the recommended inflation.
Yes, we recommend until 10, but optionally is patient-related. I mean, as I say, the lumen of the bowel is a variable, and you can inflate until you see you can see the vessel outside the bowel to avoid any ischemia in this bowel wall. You can post-operatively also you can check if you have any passage of bowel material. You can inflate some more cc into the balloon, but it depends on the experience you do. For us, the middle is the mean is 10 cc, about 10 cc.
Thank you very much. Any questions from anybody?
Sorry?
I'm just asking, any delegate is having any questions? Anybody?
In case if the patient leaks, how long can we keep the diversion tube?
In case if the leak happens from the primary colorectal anastomosis, how much time this tube can be kept?
Okay, I must say we don't have any experience of this because as I said we didn't have any leakage in this patient cord, but as far as I know we can leave the tube inside until 28 30 days. Otherwise you can switch to diverting ileostomy if it takes longer for this patient to heal the anastomosis.
Yeah, I think it can be kept for a longer period. It is only that when you keep it for longer period, some excoriation might happen in the surrounding area. But as he said, 3 times he does the irrigation with the normal saline, and you have to do twice or twice dressing if there is any mild leak. And gradually, I think it will settle there. And once your healing happens, and you have checked your primary anastomosis perfect in a lupogram or whatever CT lupogram, whatever you want to do, you then can take out this and complete the ileostomy. It is same as a ileostomy closure, but this is a tube cecostomy. Only the tube can be taken out, and the track will collapse on its own.
Yes.
Anytime you found this fistula persisting little longer, or you needed some kind of suturing or something after taking out the tube?
No, not till now. No, we didn't experience any problem after tube removal right now. But in any case, we can use stitches, endoscopic stitch, or the vacuum system to help the healing of the anastomosis in the meanwhile.
I think with that we thank you. Good night. Thank you very much.
Thank you.
Is it available in the market?
Yeah,
Bye.
it is available. It is available with in the stall. Alex is here. I think it is available here. Thank you very much. Good night.
Bye.
Thank you. Thank you very much.